cystic lung disease. As he told you, terminologies go on changing, whether to call it cystic lung disease, whether to call it cystic ILDs. And as we go through this journey, you're going to discover that half of them are not ILDs at all. Most of them are tumors. So having said that, just let's understand individual disease processes, their etiology, their treatments, and essentially what you say or what you report, how it matters. So what is a lung cyst? What is a cyst anywhere in the body? When a student is asked to describe cyst, we say something which is lined by epithelium, which is filled with fluid like a liver cyst, and it appears anechoic, gives you distal acoustic enhancement, has thin imperceptible walls. How does this translate in the lung? So you just replace the fluid with the air. So it is not filled with fluid, it is filled with air. It may or may not have a very well-defined epithelial lining, but it does have a thin wall to call it a cyst. And so this is just a zoomed out image to show you air-filled, and it's not a dilated bronchus, it's a true cyst. Then again, that nodule versus nodular pattern, cyst versus cystic lung disease. So cystic lung disease, predominantly when cysts are our predominant pattern, it becomes cystic lung disease. This is what I wanted to tell you, that the causes are really diverse. And like we tell students preparing for exam, if you are asked what can be the differentials of anything, even if you don't know anything, you will start with congenital, infective, autoimmune, neoplastic, and mostly, you'll be correct even if you don't know what comes under that. So the same thing applies to cystic lung disease. You will start with congenital, infective, interstitial, autoimmune, neoplastic, all those can be cystic lung diseases. So let's see how all those can be. There is something common in their clinical presentation and something common in the way this chest radiograph looks. And what is common in their clinical presentation is pneumothoraces. Most of the cystic lung disease will throw non-traumatic, spontaneous pneumothorax. And they absolutely hate it when you caution them against air travel soon after, they have thrown a pneumothorax. But that is one of the cautions that you take. So some will have dyspnea or shortness of breath, but a lot of them will come to attention the first time because they threw what is called a spontaneous pneumothorax. When we come to approach to a cystic lung disease, a lot of this part 2, which is excluding mimics, Bhavin covered in his talk when he was trying to say how to differentiate honeycombing, because eventually honeycombing is also like a cluster of cysts. So, but will we really call it a cystic lung disease? We will not. So, before we call something as cystic lung disease, you exclude the mimics. After you exclude the mimics, you see, are these all subplural? If they are subplural, they are still one of the mimics. Only those which are truly located inside the lung parenchyma then fall in this spectrum of cystic lung disease. So these are the steps we need to take before we reach this journey of what is a cystic lung disease. And this is the list of mimics which you need to rule out. So what is a cavity versus a cyst? Anybody, what is a cavity? Thick-walled, thin-walled may work sometimes, but cavities can also be thin-walled. So what is the difference between a cavity and a cyst? The basic difference is that the cavity always has a past. There is some sin which started the story, so to say, means there was an infection or a neoplasm. It necrosed in the center. All the muck got thrown out from the bronchus and then it emptied out and formed a cavity. That is a cavity. A cyst, by definition, is not communicating with the bronchus. So it has nothing to do with the bronchus, and it may have a past history occasionally, but it has not followed this journey. The lesion which follows this journey is a cavity or a pneumatocele. We already saw how you differentiate from bronchiectasis, from emphysema, particularly centrilobular, which shows this vessel in the center, and subpleural ones. Subpleural ones, apart from honeycombing, have all these basically smoking-related illnesses. All of these are related to smoking-related lung disease. Infections. Why are infections important? You may think that it's very obvious. Somebody has come with staph pneumonia, has gone on to develop pneumatoceles, but is it always this straightforward. This is a 12-year-old child who has presented with what looks like cystic lung disease, has a very good thymus, and we'll see later why patient has such a good thymus also for a... So what is the etiology? So you may, start racking your brains and saying, should I label it as an LCH, or do you think this can be a LAM, or till I see the previous CT from 1 year back, when the patient was microbiologically proven tuberculosis and was treated with ATT. Remember, tuberculosis will leave this signature many times. We've tried to think of why this happens, and I think the explanation is that what is the tree in bud nodule? It is inside the bronchus. What happens when ATT acts? That inflammatory exudate is resolved, that bronchus closes over there and produces cysts distally. So TB can dilate that bronchus and produce bronchiectasis, or can close that bronchus and produce these peripheral cysts, giving rise to cystic lung disease. It really looks, just to show you again, and this is a part of thymic hyperplasia which happens whenever a child recovers from an acute illness. When a child recovers, the thymus suddenly increases in size, which is a good sign because it shows that the child is recovering. So we have taken out the mimics and we have excluded infections, and we come to our 4 main cystic lung diseases that we are familiar with and how we will proceed to exclude these. These are all cystic lung diseases, not necessarily cystic ILDs, and what new terminologies have changed also, we'll address some of this as we go along. So, it's good to use less English, and when you use train AI models also, it's going to be all keyword based. So what are the keywords here? Keywords here are diffuse, bilateral, random, uniform sized. Yeah, uniform sized, number 10 or more. These are the diagnostic criteria for calling something a lymphangioliomyomatosis. What is lymphangioliomyomatosis? It's a form of neoplasm. In the last WHO classification, it was classified under picomas. Now it has been removed from picomas. It's still classified under mesenchymal tumors. Like I told you, in etiologies, you can call something congenital, infective. Suppose you are asked in any body part, how do you classify the tumors? If you know nothing about that classification, you still say primary, secondary. And the primary can be classified into epithelial, mesenchymal, and lymphoproliferative. It's just that depending on which part of the body you are, that epithelial will change. Nothing else will change. Mesenchymal are the same all over. Lymphoproliferative are the same all over. So lymphangioliomyomatosis is a mesenchymal tumor with some smooth muscle proliferation. In the standard LAM teaching, what's the patient profile that you are taught? That it's a female exclusive disease. We'll come to is LAM a female exclusive disease or not? Did you see these large lung volumes, or what are called preserved lung volumes? These are also universal to cystic lung disease. The lung volumes seldom go down in pure cystic lung diseases. You can have associated findings, you can have nodules, and what clinches the diagnosis? Serum VEGF. You can do a VEGF, and if it's more than 800 picogram, it suggests that we are dealing with LAM. Now, it can be associated with tuberous sclerosis. Is tuberous sclerosis an exclusive female disease? No. Tuberous sclerosis happens in males also. So, to understand this, there are 2 types of LAMs, even physiologically. One which is associated with tuberous sclerosis, one which is sporadic. This can happen both in male and female, and this will happen only in females. And sirolimus is employed for both, but you especially need to use it for the sporadic form. Sporadic is a bad disease which progresses very rapidly. This is one of our patients, chest radiograph alone, 2017, goes into a fibrosing type of ILD over time. The TSC LAM, tuberous sclerosis, is a more well-behaved cystic lung disease, and looks like I'm going to end up using my credits from nodule in the cyst itself. Step 2. If it's not LAM, the other entity you are familiar with is pulmonary Langerhans cell histiocytosis. The main comprehension required in this is that it is not same as the pediatric LCH in the way it looks. Pediatric LCH is a multi-system neoplasm which involves multiple organs, yeah? Liver, spleen, pituitary. This one is confined to the lung and happens in smokers. Having said that, particularly in the West, there are a lot of LCH survivors. As they go into adolescence, they become smokers, they may again develop PLCH. So it is a form of histiocytosis. So again, it's a neoplasm, but peculiar to the upper lobes and peculiar in smokers. So we already discussed what is the clinching or supportive diagnosis in this. Not in the serum, this one is in the bowel. You do the CD1A counts, and if they are more than 10%, they are taken as supportive evidence in the bowel. And initially in PLCH, you can have nodules. What is one characteristic sign? Sparing of CP angles. And this is for the standard question if you need to answer. How do you differentiate PLCH for LAM? We have seen the examples, they are vastly different. Upper lobe predominant, diffuse, bizarre, regular. The standard shape may be associated with nodules, no nodules. We now come to our third entity, no LAM, no PLCH. We have 4 entities to cover. These ones are lenticular. These ones in the lower lobe. Patient may give a history that they have other relatives who also have had spontaneous pneumothorax. This was known as what I have called it, the Berthold-Dubé syndrome, but over a period of time, it has been shown that this is due to a mutation which happens in the folliculin or the FLCN gene. It was not earlier widely available, but now this mutation study is widely available. And earlier this diagnosis rested on demonstrating lung findings with renal tumors, but nowadays you'll have a lot of patients who have only lung findings because you made the diagnosis on the basis of the gene. They have skin lesions like fibrofolliculomas, and it has been renamed as folliculin deficiency interstitial lung disease. So two were neoplasm. This is an inherited disorder. LAM also had inherited disorder also, tuberous sclerosis. This is specifically due to a gene deficiency. It is very oblong, runs, these are the key words here, encase or run parallel to pulmonary veins in the lower lobes. These ovoid-looking lesions are diagnostic. We now come to the last entity of the 4 classical cystic lung diseases, which is lymphoproliferative interstitial pneumonia. Again, what form of disease it is? Lymphoproliferative. What are lymphoproliferative disorders and what are the risk factors? At one extreme end of the spectrum, we understand lymphoma, isn't it? But LIP is always also in the same spectrum. Which patients do you get it in? You get it in HIV, but you also get it in patients of Sjogren. So one is autoimmune disease and one is hypoimmune. Remember, autoimmunity and hypoimmunity are both disimmunities. Basically, dysregulated immunity give rise to dysregulated lymphoproliferative proliferation. So very similar diseases. Both lymphoma and LIP can happen in HIV also, can happen in Sjogren's also, because they are linked to disimmunity. What are the characteristic imaging features? So these are the key words. Peribronchovascular, small tiny cysts, associated ground glass, associated centrilobular nodules. In an adult, commonest cause Sjogren. In a child, commonest cause HIV. And lastly, we did everything, but we still can't make the diagnosis. It's not a mimic, it's not an infection, doesn't fit into those 4. So our last resort, what Bhavin already covered very nicely, pattern approach. Ground glass plus cyst. Let's do a pattern approach, combine 2 findings, then these are our differentiations. LIP, all these smoking-related illnesses, and PJP. Next combination. Interstitial thickening with cyst. Almost every fibrotic ILD can have them, but classically in LIP, I'm going to show you one more disease, which is ARDS follow-up. When I do case discussion, I will briefly talk about what is ARDS. Fibrotic BIP, this is a BIP in a child, but still has lot of cysts. So two combinations we saw, ground glass plus cyst. This is fibrosis plus cyst. And lastly, nodule plus cyst. Nodule plus cyst we already saw. Apart from LCH, there are a lot of other entities such as vasculitis, amyloidosis, and some of these entities, again, I will discuss during the case base. So our approach has been exclude infections, exclude mimics, exclude the four classical, and if none fit, look at combination patterns. I've tried to fit in where clinical plus imaging is enough to make a diagnosis, where serology plus clinical plus imaging is enough to make a diagnosis, gene mutation is enough to make the diagnosis. Occasionally, you will need a lung biopsy. Either transbronchial will not help, so VATS assisted or surgical. So this brings us to the end of this stepwise approach. Thank you very much.